Good morning to all of you. It is truly my honor and pleasure to be here, and I'm going to quickly give you an overview of what's new in pigmentary disorders. These are my disclosures. I have no conflicts beyond having participated in a number of the clinical trials that I will share with you this morning. So let's first look at the absolute devastation, the psychological devastation of pigmentary disorders, in particular vitiligo. It robs patients of their dignity, it erodes the soul, it causes low self-esteem and stigmatization. And I think it's extremely important that you always look at the impact of this disease in considering therapeutic intervention. So what are our therapeutic advances? We really have moved forward in the world of pigmentation research. I think we have substantial evidence-based medicine on the use of topical and systemic corticosteroids, the calcineurin inhibitors, phototherapy, narrowband UVB, the excimer laser. So I'm not going to spend time on these modalities nor grafting. We really will focus on what is truly new. When you think about treating vitiligo, I really want you to think about it within the context of you must use a multimodality approach. That multimodality approach includes stabilization, repigmentation, being able to maintain what you've achieved. And I think if we can achieve these, this type of intervention, then invariably we improve the quality of life of patients suffering from this disease. Now, I summarized a substantial amount of new data here for you on this slide, and that is, how do we approach stabilization? There are multiple new studies in looking at different agents for stabilization. There's oral mini pulse therapy. You can use it in a dose of 2.5 milligrams on 2 consecutive days per week. There's methotrexate that's been compared to oral mini pulse dosing, equal efficacy, 10 milligrams per week. There's minocycline in a dose of 100 milligrams a day. I happen to like intramuscular triamcinolone. I've used it for at least 20 years. We give up to 3 doses at 4 to 6 week intervals, up to 3 times, and it's been extremely effective for us at my institute in achieving stabilization. And keep in mind, narrowband UVB that we use as a repigmenting agent for those individuals with greater than 10% involvement. Multiple new studies suggesting that narrowband is also extremely effective as a stabilizing agent for vitiligo, and new data on oral antioxidants that can be used often in combination with narrowband UVB. And I will be talking about oral antioxidants in my lecture on Monday. So where are we now? What's new and exciting? What are the emerging therapies? I want to talk about four modalities: alpha-melanotide, the synthetic analog of alpha-MSH, the prostaglandin F2 alpha analogs, the Jak inhibitors, the new small molecules, and PRP. So what about alpha-melanotide? I hope that this drug will soon come to the marketplace. This is our work in 56 patients. It was a 6-month treatment trial. We compared the synthetic analog in combination with narrowband UVB to narrowband UVB as a monotherapy. We achieved maximal repigmentation in the individuals on the combination group, and moreover, the very best outcomes were achieved in our darker racial ethnic groups. We think that the probable mechanism of action was upregulation of melanoblasts in the outer root sheet of the hair follicle. Now, there were 3 new studies in 2016 on the prostaglandin F2 alpha analog. So I think there's probably some global interest in these agents as repigmenting modalities for vitiligo. The agents that are readily available in the United States are latanoprost and Matterprofs. How do they work? They increase melanogenesis, they increase melanocyte proliferation, as well as increasing the transfer of melanin to epidermal keratinocytes. I talked about Anbar's work last year 2 papers this year in 2016 from Torello Leidy's group, and then our paper on Matterprofs. And I'll just share a little bit of our paper. We enrolled 32 patients. Unfortunately, the FDA would not allow us to treat the face, so we could only treat non-facial lesions with the 0.03 solution. And this was a comparative study. We looked at Matterprofs as a monotherapy, Matterprofs in combination with a topical steroid, mometasone, versus the mometasone and placebo. So 18 patients completed the study. We looked at those individuals who ultimately achieved 25 to 50% improvement, maximal improvement in the combination group of Matterprofs and mometasone, as you see on this slide. Side effects were minimal, and I think we're going to see more in the future on this class of drugs as repigmenting agents for vitiligo. And they probably do work best in combination with other modalities. In Anbar's work, he got the very best responses when he used it in combination with narrowband UVB phototherapy. This is an interesting paper on using platelet-rich plasma in combination with narrowband UVB as a repigmenting agent for vitiligo. This is Ibrahim's work, 60 patients with stable vitiligo. They had to have symmetrical lesions. Both sides of the body were treated with narrowband UVB and PRP on one side. The PRP was performed every 2 weeks for 4 months. And as you see on this photo, there was significantly greater improvement on the side treated with PRP and narrowband. I call the Jak inhibitors the new babies on the block for vitiligo. These small molecules, they block the JAK-STAT signaling pathway, decreasing CXCL10. 2 case reports in 2015, 2016, one using tofacitinib, which inhibits JAK3, and the other case report from John Harris's group using ruxolitinib, which inhibits JAK1 and 2. And these are the photographs. Here, if you look at the top photographs, it's difficult to repigment hands, but significant improvement in treating vitiligo on the hands. Tofacitinib worked, and the ruxolitinib had a significant impact on the face. However, upon discontinuation, the pigmentation faded. So I think, given the interest, we're going to see substantial new data in using these agents as repigmenting agents for vitiligo. Just to comment on supplements, vitamin D deficiency, I think, is rampant in patients who have vitiligo, and there's a whole body of literature now in looking at vitamin D levels in autoimmune diseases, vitiligo. So I pick up deficiencies on an ongoing basis. I do screen my patients. If they have true deficiency, you got to treat them with 50,000 international units of vitamin D once a week for 3 months, and then you switch them to maintenance. Now, this is a very interesting study looking at the effect of, this was a pilot study, looking at the effect of prolonged administration of high doses of vitamin D as a repigmenting agent for vitiligo and psoriasis. They enrolled 16 patients. They used a higher dose, 35,000 international units once a day for 6 months. The patients were on a low calcium diet with significant hydration, and interestingly, you can see substantial repigmentation of the face. So I pretty much supplement. I don't use these types of high doses, but everyone gets supplemented. So now I'm going to flip the switch, and let's talk quickly about hyperpigmentation and melasma. And I think that this is probably an even more complicated disorder given the complexities in the pathogenesis as well as the treatment of this disorder. Now, first thing, sunscreens, new data on the need for visible light protection if we're going to stabilize patients. This is work using a visible light sunscreen in 68 patients. The visible light sunscreen that we have that's available is iron oxide, much better improvement in the group with iron oxide plus our standard UVA filters versus UV protection alone. These patients were treated with hydroquinone as well. And in the other study of 46 patients from Passeron's group in Nice, they had two formulas, Formula A, Formula B. Formula A contained an additional iron oxide sunscreen. Again, significantly greater reduction in the MOSI score using additional iron oxide protection. We can also use polypodium leukotomus. The brand name is Heliocare. Studies suggesting that it probably does make a significant difference as an oral sunscreen in a dose of 240 milligrams twice a day. Now, I'm showing you multiple bleaching agents here. Most of our bleaching agents are in that blue group. They are tyrosinase inhibitors. Hydroquinone, unfortunately, it's been around 40, 50 plus years, but it's still the king of the road. We have other effective old agents, azelaic acid, kojic acid. So where are we? If we go around the globe and look at evidence-based studies, most of these global studies suggest that combination therapies are vastly superior to monotherapy. Triple combination probably works better than any other agents that we have. They don't cause atrophy if they contain a fluorinated steroid. And the formula varies, I think, from country to country. And if we look at peels and lasers, I think most would agree that the outcomes are mixed. Now, what about non-hydroquinone agents? Lots of new, controlled, evidence-based studies suggesting that we have a stable of new non-hydroquinone agents that probably offer some efficacy. Some of these agents are comparable to what we can achieve with hydroquinone. One of the newest agents is Litera 2, which has been reformulated. New ingredients. It does contain tranexamic acid, and I'm going to talk a little bit about tranexamic acid. But all of these agents are approved, and we have data to suggest that they work. Now, given the non-hydroquinone agents with efficacy versus hydroquinone, how do we process all of this? Well, this is a way that I'd like to present it to you. If you look at the long-term management of melasma, given we have nothing that's superior to hydroquinone, you may want to start there. Keep that patient on hydroquinone for 6 months, and then you rotate. So I want you to make an imprint of thinking always about a rotational algorithm when you're treating melasma, because invariably, given the current tools in our toolbox, those patients will flare and they will require long-term maintenance. Now, I'm going to quickly go through what I consider the vascular story, and you must know the vascular story of melasma. 10 years ago, we thought the vascular story was a topical steroid story, and we now know better. We know that a substantial cohort of patients with melasma will have vascular lesions. Why do they get these lesions? We now think that if you look at the cells in the skin, the crosstalk between cells, mast cells are probably major players in this process. If you look at all the changes in melasma, mast cells are increased in the skin of patients with melasma, and that's been documented in multiple studies. They increase hyperpigmentation. They increase elastosis that we see in the disease. They cause vascular proliferation. They can degrade type 4 collagen. We know that basement membrane is abnormal. So, what's of impact? Get multiple studies from Asia now on tranexamic acid. And if you tease out those studies, the tranexamic acid is probably having an impact on mast cells as much as it's impacting pigmentation. And this is a very nice study looking at the histologic changes at 8 weeks of treatment with tranexamic acid. And so what do we see? We see reduced epidermal pigmentation, reduced levels of vascularity, as well as reduced numbers of mast cells. So I think this is really exciting data. And if you look at, again, how do we treat it? This is a patient that we treated with salicylic acid peels and a long pulse ND YAG laser. She had a significant vascular component. We got some improvement. This is Passeron's work. They used triple combination bleach plus a pulse dye laser on one side, significant improvement. And this is Friedman's work where they used they treated the vascular component with a 595 fractional low-powered diode laser, 11 patients. They also used a 1927 low-watt combination, and 54% of those patients had greater than 50% improvement. So I think we're going to see more addressing the vascular component of melasma in the future. Emerson Lima is speaking in my session in the afternoon on melasma, on microneedling for patients who have moderate to severe disease. You use topical lidocaine first. His needle length was 1.5 millimeters. He used triple combination bleaching, and significant improvement in patients with moderate to severe disease. I think we're going to see more of this in the future. So I'll close with, again, for melasma, that rotational algorithm. If you're in that, what I will call a more aggressive clearing phase, you certainly can use hydroquinone. You have multiple tools there, but there are no cures for melasma, and you must remember the rotation. You will constantly rotate from clearing, maintenance. When those patients flare, you will go back to your clearing phase. So I think this is where we are in the treatment of vitiligo and melasma. So we continue to move forward with new innovations, new therapies for these disorders. So I thank you for your time and attention.